drinking water of the next host if proper sanitation measures are not in place. 32. The cholera toxin, CTX or CT, is an oligomeric complex made up of 6 protein subunits, a single copy of a subunit, part A, and 5 copies of the B subunit, part B, connected by a disulfide bond. The 5 subunits form a 5-membered ring that binds to GM1 gangliosids on the surface of the intestinal epithelial cells. The A1 portion of the A subunit is an enzyme that ADP ribosylates G proteins, while the A2 chain fits into the central core of the B subunit ring. Upon binding, the complex is taken into the cell via septor-mediated endocytosis. Once inside the cell, the disulfide bond is reduced, and the A1 subunit is freed to bind with a human partner protein called ADP ribosylation factor 6, ARF6. 33. Binding exposes its active site, allowing it to permanently ribosylate the GS-alpha subunit of the heterotrimeric G protein. This results in constitutive CAMP production, which in turn leads to the secretion of water, sodium, potassium and bicarbonate into the lumen of the small intestine and rapid dehydration. The gene encoding the cholera toxin was introduced into V. cholerae by horizontal gene transfer. Virulent strains of V. cholerae carry a variant of a temperate bacteriophage called CTX. Microbiologists have studied the genetic mechanisms by which the V. cholerae bacteria turn off the production of some proteins and turn on the production of other proteins as they respond to the series of chemical environments they encounter, passing through the stomach, through the mucous layer of the small intestine, and onto the intestinal wall. 34. Of particular interest have been the genetic mechanisms by which cholera bacteria turn on the protein production of the toxins that interact with host cell mechanisms to pump chloride ions into the small intestine, creating an ionic pressure which prevents sodium ions from entering the cell. The chloride and sodium ions create a saltwater environment in the small intestines, which through osmosis can pull up to 6 liters of water per day through the intestinal cells, creating the massive amounts of diarrhea. The host can become rapidly dehydrated unless treated properly. 35. By inserting separate, successive sections of V. cholerae DNA into the DNA of other bacteria, such as E. coli that would not naturally produce the protein toxins, researchers have investigated the mechanisms by which V. cholerae responds to the changing chemical environments of the stomach, mucous layers, and intestinal wall. Researchers have discovered a complex cascade of regulatory proteins controls expression of V. cholerae virulence determinants. 36. In responding to the chemical environment at the intestinal wall, the V. cholerae bacteria produce the TCPP/TCPH proteins, which, together with the TOX-R/TOX-S proteins, activate the expression of the TOX-T regulatory protein. TOX-T then directly activates expression of virulence genes that produce the toxins, causing diarrhea in the infected person and allowing the bacteria to colonize their intestine. 34. Current research aims at discovering the signal that makes the cholera bacteria stop swimming and start to colonize, that is, adhere to the cells of the small intestine. 34. Genetic structure. Amplified fragment length polymorphism fingerprinting of the pandemic isolates of V. cholerae has revealed variation in the genetic structure. 2 clusters have been identified, cluster I and cluster II. Fourth most part, cluster I consists of strains from the 1960s and 1970s, while cluster II largely contains strains from the 1980s and 1990s, based on the change in the clone structure. This grouping of strains is best seen in the strains from the African continent. 37. Antibiotic resistance. In many areas of the world, antibiotic resistance is increasing within cholera bacteria. In Bangladesh, For example, most cases are resistant to tetracycline, trimethoprimsulfamethoxazole, and erythromycin. 38. Rapid diagnostic assay methods are available for the identification of multidrug resistant cases. 39. New generation antimicrobials have been discovered which are effective against cholera bacteria in vitro studies. 40. Diagnosis. A rapid dipstick test is available to determine the presence of V. cholerae. 38. In those samples that test positive, further testing should be done to determine antibiotic resistance. 38. In epidemic situations, a clinical diagnosis may be made by taking a patient's history and doing a brief examination. Treatment via hydration and over-the-counter hydration solutions can be started without or before confirmation by laboratory analysis, especially where cholera is a common problem. 41. Stool and swab samples collected in the acute stage of the disease, before antibiotics have been administered, are the most useful specimens for laboratory diagnosis. If an epidemic of cholera is suspected, the most common causative agent is V. cholerae 01. If V. cholerae serogroup 01 is not isolated, the laboratory should test for V. cholerae 0139. However, if neither of these organisms is isolated, it is necessary to send stool specimens to a reference laboratory. Infection with V. cholerae 0139 should be reported and handled in the same manner as that caused by V. cholerae 01. The associated diarrheal illness should be referred to as cholera and must be reported in the United States. 42. Prevention. Preventive inoculation against cholera. In 1966, the World Health Organization, WHO, recommends focusing on prevention, preparedness, and response to combat the spread of cholera. 35. They also stress the importance of an effective surveillance system. 35. Governments can play a role in all of these areas. Water, sanitation and hygiene. Although cholera may be life-threatening, prevention of disease is normally straightforward if proper sanitation practices are followed. In developed countries, due to their nearly universal advanced water treatment and sanitation practices, cholera is rare. For example, the last major outbreak of cholera in the United States occurred in 1910-1911. 43. 44. Cholera is mainly a risk in developing countries in those areas where access to water, sanitation and hygiene infrastructure is still inadequate. Effective sanitation practices, if instituted and adhered to in time, are usually sufficient to stop an epidemic. There are several points along the cholera transmission path at which its spread may be halted. Sad smiley. 45. Sterilization, proper disposal and treatment of all materials that may have come into contact with the feces of other people with cholera, for example, clothing, bedding, etc., are essential. Feces should be sanitized by washing in hot water, using chlorine bleach if possible. Hands that touch cholera patients or their clothing, bedding, etc., should be thoroughly cleaned and disinfected with chlorinated water or other effective antimicrobial agents. Sewage and fecal sludge management. In cholera-affected areas, sewage and fecal sludge need to be treated and managed carefully in order to stop the spread of this disease via human excreta. Provision of sanitation and hygiene is an important preventative measure. 35. Open defecation, release of untreated sewage, or dumping of fecal sludge from pit latrines or septic tanks into the environment need to be prevented. 46. In many cholera-affected zones there is a low degree of sewage treatment. 47. 48. Therefore, the implementation of dry toilets that do not contribute to water pollution, as they do not flush with water, may be an interesting alternative to flush toilets. 49. Sources. Warnings about possible cholera contamination should be posted around contaminated water sources with directions on how to decontaminate the water. boiling, chlorination, etc., for possible use. Water purification. All water used for drinking, washing, or cooking should be sterilized by either boiling, chlorination, ozone water treatment, ultraviolet light sterilization, for example, by solar air water disinfection, or antimicrobial filtration in any area where cholera may be present. Chlorination and boiling are often the least expensive and most effective means of halting transmission. Cloth filters for SARI filtration, though very basic, have significantly reduced the occurrence of cholera when used in poor villages in Bangladesh that rely on untreated surface water. Better antimicrobial filters, like those present in advanced individual water treatment hiking kits, are most effective. Public health education and adherence to appropriate sanitation practices are of primary importance to help prevent and control transmission of cholera and other diseases. Hand washing with soap or ash after using a toilet and before handling food or eating is also recommended for cholera prevention by WHO Africa. 50. Dumping of sewage or fecal sludge from a UN camp into a lake in the surroundings of Port-au-Prince is thought to have contributed to the spread of cholera after the Haiti earthquake in 2010, killing thousands. Dumping of sewage or fecal sludge from a UN camp into a lake in the surroundings of Port-au-Prince is thought to have contributed to the spread of cholera after the Haiti earthquake in 2010, killing thousands. Example of a urine diverting dry toilet in a cholera-affected area in Haiti. This type of toilet stops transmission of disease via the fecal-oral route due to water pollution. Example of a urine diverting dry toilet in a cholera-affected area in Haiti. This type of toilet stops transmission of disease via the fecal-oral route due to water pollution. Cholera hospital in Dhaka, showing typical cholera beds. Cholera hospital in Dhaka, showing typical cholera beds. Surveillance. Surveillance and prompt reporting allow for containing cholera epidemics rapidly. Cholera exists as a seasonal disease in many endemic countries, occurring annually mostly during rainy seasons. Surveillance systems can provide early alerts to outbreaks, therefore leading to coordinated response and assist in preparation of preparedness plans. Efficient surveillance systems can also improve the risk assessment for a modeling approach using satellite data can enhance our ability to develop cholera risk maps in several regions of the globe. Potential cholera outbreaks. Understanding the seasonality and location of outbreaks provides guidance for improving cholera control activities for the most vulnerable. 51. For prevention to be effective, it is important that cases be reported to national health authorities. 17. Vaccination. Uvicol plus oral vaccine for cholera. Spanish physician Jaume Fernández developed first successful cholera inoculation in 1885, the first to immunize humans against a bacterial disease. 52. His vaccine and inoculation was rather controversial and was rejected by his peers and several investigation commissions, but it ended up demonstrating its effectiveness and being recognized for it. Out of the 30,000 people he vaccinated, only 54 died. 53, 54, 55, 56. Russian Jewish bacteriologist Waldemar Hafkine also developed a human cholera vaccine in July 1892. 53, 54, 55, 57. He conducted a massive inoculation program in British India. 55, 58. Persons who survive an episode of cholera have long-lasting immunity for at least 3 years, the period tested. 12. A number of safe and effective oral vaccines for cholera are available. 59. The World Health Organization, WHO, has 3 pre-qualified oral cholera vaccines, OCVs Dukoral, Syncol, and Uvicol. Dukoral, an orally administered, inactivated whole cell vaccine. has an overall efficacy of about 52% during the first year after being given and 62% in the second year, with minimal side effects. 59. It is available in over 60 countries. However, it is not currently recommended by the Centers for Disease Control and Prevention, CDC, for most people traveling from the United States to endemic countries. 60. The vaccine that the U.S. Food and Drug Administration, FDA, recommends, Voxera, is an oral attenuated live